RHU is a local organizations, and we basically specialize in sexual and reproductive health services. And we have different branches across the country. Iganga is one of them. Our offices in Busoga region is in Iganga along Kaliro Road. We have our clinic there and our youth center where we base to reach out to different areas in the region. But we have other regions. You see colleagues from Tororo, they are here. We have other colleagues in the Eastern, Mbale, and Kapchora. Those are the branches. And my colleagues from RHU who are on the call, you're also most welcome. Specific calendar wish to action, I'm sure you're seeing it there. Wish to action is the Women Integrated Sexual Health Project that we are implementing in the region, in 6 regions of Uganda. That is the Central, Kampala, Busoga, Bukeddi, Tororo, Mbale, Bugisu, Acholi, and Lango. And we are implementing it in a consortium of 6 partners. IPPF, which is represented by RHU, Reproductive Health Uganda. And we also have Rescue International, IRC, International Rescue Committee, and Maristops. We do service delivery on the project. And then options, they do advocacy and national ownership. Then humanity and inclusion focuses on inclusion of persons with disability. Then development media is responsible for SBCC or demand creation activities. So we work in a consortium, and the project is funded by UK Aid, which is the FCD of UK government. So the project we've implemented since 2019, and we are in our 4th year of implementation. So we are going to be sharing what we have on board as far as demand creation is concerned. We focus on increasing access to sexual and reproductive health services, integrated sexual reproductive health services with a special focus on family planning. And our focus is to increase access to modern contraceptive services, but also increase new users of family planning, reaching the poor of the poorest communities. As you're aware, poor people have challenges in accessing services, but also we are targeting young people under 20, given the teenage pregnancies in the country. But also we are looking at sustainability. So that's why we have a range of partners, and each of them has a different component to play, and our work is interrelated. So back to SBCC specifically, the subject matter of the day. SBCC, we define it as the systematic application of interactive, theory-based, and research-driven communication processes and strategies. So whatever strategies we use, they are evidence-based. Research has been done about it to see that it creates impact and creates change in people's individuals. You know, people's behaviors are difficult to change. So these strategies target change across a continuum from individual level to the community, but also at society level. So a range of stakeholders are targeted. SBCC contribute, when we look at SBCC, why SBCC? You discover that the biggest burden of diseases can be prevented. For example, you have diseases like malaria, HIV, injuries or accidents, deaths that are related to the commonest preventable causes, maternal deaths, teenage pregnancies, and abortion are the leading contributor of maternal mortality, and all these could be prevented. So SBCC is very important as far as the impacting and the contributing to knowledge, changing attitudes, and improving behavior, as well as health outcomes within our communities. So it's a very important approach to improve health outcomes of our individuals. When you look at these three, these animals on this slide, what do you think if you're to rate these pictures, all these pictures you're seeing? You have a lion, you have a human being, you have a motor vehicle, you have a mosquito, you have a crocodile. Which of these do you think could be causing the highest mortality if you're to rate? You can type in the chat.
Yes, well, let's utilize the chat box in responding to some of these questions. Yeah, just
Somebody
like
saying
what's
mosquito.
asked. We see we have mosquito here. Yeah, please let's utilize the chat box.
Somebody
I see
saying
human
human being.
mosquito here.
Cyrus mosquito. I see Dauda mosquito. We are 28, but I'm seeing few responses.
Yes, well, I think this should really be interactive. So much interactive.
Edward is saying mosquito. So the winner will go with a gift at the end. Anita is saying human being.
So we have 2 human beings.
The response is over. Human being. Okay.
We also have another human being coming on.
Are we done with the responses? We are over 30. Joanna is saying mosquito. Kakai is saying human being. Frank Vogere is saying human being. Okay. So who has won the gift at the end of the session? Okay, so the leading cause of death is the mosquitoes kill majority. But when you look at it, they are easily preventable based on our behaviors as human beings. You have a lot of interventions that have been put. Recently in the region, we've been struggling with a pandemic of malaria. And yet when you look into what relate to that, it's the human behaviors, the way people behave towards the use of the preventive measures. So a brief background as the project, when you look at a snapshot of our indicators, before the project started in 2019, Uganda already had made commitments to reducing unmet need. This project is contributing to the UK's commitments of the FP 2030 of in Africa, and in Uganda specifically, we also made commitments, and we had planned to increase our contraceptive prevalence rate by up to 50%. We also aim to reduce unintended pregnancies and reduce maternal mortality and morbidity. But also when we reflected on the indicators, by then fertility rate was also high, as you can see. Women using modern contraceptive were around 3 million. We also had contraceptive, because of the low use of contraceptives, we had modern contraceptive use had increased, though it was still low by 2020. The percentage of women who were not satisfied by modern contraceptives, they were also high at around 55.9 by 2020. Unmet need was at around 20.9 for married women by 2021. And when you compare all those demand, the unmet need, the low contraceptive prevalence, we're likely to have, by the coming in of the project, we targeted to avert unintended pregnancies of about 1,252,000 if we had increased access to contraceptives. But also we were looking at reducing 255 unsafe abortions and about 2,800 maternal deaths if the demand was satisfied with the modern contraceptives, and if we had an increase in the number of new users, and if we had reduced on the unmet need. So as WISH, this is one of the UK's program for increasing access to SRHR. It's a multi-country project that is implemented in several countries, and the first phase ended in this year, and we are continuing up to 2023 for our costed extension. So we are in our new costed extension. Our targets, basically, one is on individual choice. We want to strengthen the individual knowledge and build communities to support SRHR. This is where our SBCC comes in to support individuals make right choices as well as the communities to be supportive. In terms of national ownership, we want to look at sustainability and ownership of SRH interventions, but also want to increase access to services by improving access to voluntary family planning and other SRH services. And then we want to contribute to global goods by increasing women's choice to access services through evidence-based and innovations as well as practices. These are the partners we work with on the project. I highlighted them earlier. Our model of delivery, of course, we work through the static facilities, both public and private. We use the outreach model and also work through the community distributors. So all these are service delivery points leverage from our SBCC interventions to increase access. From what the basis of coming up with these tools that we are sharing, our tools are also developed, our interventions are developed based on research and data-driven. And in 2021, we did the client exit interviews on clients that we were serving. And the majority of our clients we were serving were in rural areas. And this map shows the sampling. 53% were from Eastern region, where we belong. So we constituted the majority. But also when we look at the demographics of the clients we're serving by then, we had the 19% and then 28% under 20. So the young people almost contributed the biggest percentage when you add the 19 plus 28. It's a big percentage of young people we are serving. And most of them are dependent on agriculture, while 70% had 2 or more children. So when you look at this age group, if majority of the clients are between 19 and 28, and we compare with the majority having 2 or more children, it means that we are having a high burden. So we need to develop innovations that can really address the demand and the need. But also we looked at the usage in terms of media. We noted that a third of a client had never listened to radio. Of course, majority, 65 of these clients we served according to that survey were under poverty. People who were poor, they are living in, according to our status of poverty, living below $1 per day. The housing, normally it's grass thatched. They have no latrine, they don't own radios, they don't own assets. So those were the majority. And among the clients who reported to listen to radio, we had only 64 listening it from their homes, 23 from friends, 5 from the community, 2% were at work, and 1 from public spaces. So this graph on the right, it gives us avenues of where we can target our messages to reach the people in the communities that we are serving. But also on your left, you see that 38% had never listened to radio. But also when you look at the frequency at which they listen to radio, it is very, very low. So initially we had the radio spots that were being played on radio. But this was to assess how far the people listen to these messages on radio, which we call the above the line SBCC interventions. Then we also had the jingles playing on TV at the beginning, and we found that 76% of the communities we were serving were not listening, were not watching TV. We had only a small percentage who were watching TV. And when you compare those who were watching TV, because we had the sports that were running on TV, only 31 had to watch them at, majority were watching at friends' houses, only 28 had them at home. 13 were from public places, 10% were from the community. We had the 7% who were watching from drinking places, bars, 2% at work, and 1% at the clinic or at the facility. So these areas where people watch are important. They guide our targeting. Where can we target? If majority of the people don't own TV, then what avenues can we use to reach them out with our messages? As you are aware, the audio-visual messages, they impact a lot on people. So when we looked at the number of clients who were living under poverty, who never listened to radio, you find that the biggest percentage of the clients living under poverty never listened to radio. So it means our poor people in Mayuge down there in the forest reserve, on the lake shores, who are very poor, they can't listen to radio. It means that these messages cannot reach them. So we had to innovate ways of reaching to them, because you see those who listen at least once, they are the majority, 1 to 3 days. So very few listen every day to the radio, which makes it challenging for our messages to reach. So for us, we may be putting messages on radio and thinking that they are getting, and yet for behavior change to occur, we need to use a range of approaches. We looked at people who access phones, who are living in poverty. Remember, I told you 65% were in poverty, but of those, only 81%, only 54% had access to the phone. 81 had no phone. And this was not different among the youth, those who were non-youth, or even those who are disabled. So there was no significant difference. So they are equally affected. So as a wish, what strategies did we focus on in our engagements? We are focusing on male engagement based on the feedback that we had seen and the lessons we had learned from the study. We're looking at now focusing on engaging male because it's a big challenge in the region and even across the country, targeting the youth, the poor, and the persons with disability in our SBCC strategies. Is what we are looking at in this costed extension. And the strategic approaches we are using, which are using all above the line and below the line. And above the line, we are looking at integrated talk shows, community radio towers, the Vizinda law, the hybrid interventions, which integrates mass media and then interpersonal communication. But also we are looking at the below the line activities, the community dialogues, the engagement using radio, video, but also we are looking at the pivotal tools, which are the talking cards, that based on the people who are in poverty, who can't access radio, who can't access the talk shows, we came up with the pivotal tools, the talking cards, to be able to reach these people with messages. We have also one-on-one and community drive, and then integrating the cards in Omwe. So these are other interventions that we are looking at to use. So the talking cards specifically, this is a new innovation that came up because we wanted to reach many young people. In this picture, the cards look like this. They are small, as I'll be playing for you later. So these are the cards. Here we're launching these cards in Mayuge, and they have two. They are the video and then the audio cards, and this how the district people were listening to have a feel of how the cards play. This is one of the engagements, male engagement in the community, using the cards that we play, and they listen to the messages, as you can see them listening to the messages. Here is another engagement with you see the cards are here. There are many. Men are listening to the cards. There are also these young women you're seeing here, viewing the video card. These ones are also looking at the audio card. So the same messages on the audio card, we also distribute them on local radios. They are played on local radios because the local radios are closer to the communities. So the same messages on the cards are also used on the local radios as you're seeing them. We also looking at using additional engagements like community dialogues. We shall continue using them, integrating alternative media like cinema halls. We are looking at cinema halls, buses, and outdoor screens where they are applicable. And then the health workers and peer educators, the VHTs, These ones are also to use them. We're also looking at the facilities where we give them messages, those that have TVs, WhatsApp groups. Some of these messages can be shared via the WhatsApp groups, using the local radios, the vision that I've shown, and the community film shows, as well as school activation campaigns. These are the interventions that we are looking at to use. Of course, for any interventions, we need to have tools for guiding us in terms of data collection. We have our SBCC strategy, family planning mobilization strategy, and the poverty heat map that we use to locate areas that are under poverty. So the poverty I don't know whether I'll be able to show you, but it shows areas under poverty, so we are able to target the people under poverty. Also, to assess our interventions, we have the rumor tracking, the exit forms for the clients who have been exposed to the SBCC, but also we have the SBCC material tracking tools that we use in our interventions. For us to be able to collect data, of course, we need indicators in SBCC. So for the VHT at community level, we look at the number of activities they have done because we give them the cards, and then the reach by gender, the people they have referred, the dialogue meetings, and also qualitative feedback from the community in terms of needs, perceptions about the services. So these reports come to the cluster at the regional level, where we have summary of the VHT reports, review meeting, dialogue meetings. So we keep on tracking their indicators, and then we submit at the national level. So we keep on tracking these indicators to assess the intervention of our SBCC and the outcomes. Of course, for any interventions, there are challenges. For example, the talk shows, during the COVID period, as we're implementing them, we had challenges of curfew, but now it was lifted. COVID, of course, affected school programs. We couldn't go to schools, and some messages were targeting the young people in schools. Numerous languages, of course, for example, in Busoga, you find some regions speak Samia. In Busoga, you have the Busoga, which sometimes the translation is difficult. The cards we have currently are in Uganda and English, but you find that translation also takes a longer period and approval. So there are so many languages that are spoken. People are interested in the video cards, but they are few, of course, given that they are more expensive to produce. But also we have the unhealthy social norms and cultural beliefs. So the question we ask ourselves is, what opportunities do we have as the members, as implementing partners? What opportunities can we have as far as that we can use to leverage on these tools? As we look at that question, I would like to share some of the messages that are on those cards. Let me just get one of them. Are you able to see?
No.
As you play the video, I think we should also utilize the chat box to respond to this question. Would like to see
Wala mama, hangene nyamba kusenga ku hotel. Namuga. Oh. Umwana sambanya. Ostude bola. Kitawe. Ukereye. Nsani wasenga. Mbadde nyama mama kubana. Nini. Oyo muganda wange agezaako kuzza mubiri. Okufumula abaana okunywa okumussi kyangu. Ani oyo? Tabani wa Busisi nyenenje. Naggayi, yogera ne kasitoma oyo. Tugenda kwogera Ssenga.
Oh, nchifuye. Nze mwebe. Ate kwe.
Naggayi. Namuka. Omwana ng'eyeetaaga omusawo yanguwa. Wasukumukayo ssebo.
Bambi katusuubira agenda kuba bulungi.
Kyabulaba abawala ab'emyaka gy'okufuna embuto emibiri gyabwe gye bategyetegese kimala.
Kituufu nnyo okulindako okufuna olubuto okutuusa ng'omubiri gw'omukyala gugumye kirungi eriye era n'omwana.
Lindirira ekitundu ekyokubiri omanye ekyaddako.
So this is one of them. That is a series. So it has about 6 parts, but we also have others like this one I'm going to share. So the series has over 6 parts. So that was one of the series, one of the parts. But we have also others like this one.
Lala, twalonda ka implant. Kanziza okufuna obuto okumala ebbanga eddeneko. Nkozesa ka implant mwaka kola okumala emyaka 3. Ate tekanziza kuyosa mwana wange. Olw'okuba nze maama ate nga nze taata nfuba nnyo okusobola okulabirira abaana. Era nali neetaaga enkola ennyanguira. Okujjukira buli lunaku okumira obuweka obunziiza okufuna olubuto kyali kizibu.
Yensonga lwaki twalonda ka implant.
Ka implant ka plastic era kagonda kateekebwa wansi w'olususu ku mukono. Nafuna akange era naddayo okunkebera nga nakamala okuzaala. Omusawo bwe yali akanteekamu yakozesa ekyuma ekyenjawulo okugeeza yalinga akuba empiso ku mukono. Ka implant kagumu tekaseseetuka ate era tekakutuka. Bwe mba njagala okufuna omwana omulala nga ngenda mu ddwaliro nga bakanzijamu nanziramu okufuna omwana omulala. Kirungi obuteraliikirira nti nja kufuna olubuto nga seetegese.
Ka implant kawangazi era keesigika. Genda mu ddwaliro owabule ku nkola ezitangira okufuna embuto ezitali nneetegekere osobole okulonda ekugwanira. Jjukira omupiira we bwokka obutangira okufuna akawuka ka siriimu wamu n'endwadde endala eziva mu kwegatta.
So those are some of the messages. There are different messages on different methods, but also there are those that are targeting young people, addressing myths and misconceptions. Yeah, on other SRH issues. Kim, I think I can hand over to you.